Welcome, everyone. This is the COVID-19 and Emerging Infectious Diseases track. This session is Cherokee Nation Hepatitis C Elimination Program. Our presenter today is Dr. Jorge Mera. Dr. Mera is the Director of Infectious Diseases for Cherokee Nation Health Services. His work has focused in the CNHS response for the COVID-19 pandemic, as well as, hold on just a second. Sorry, someone rang the doorbell. Where was his work is focused on the CNHS response to the COVID-19 pandemic, as well as directing the CNHS Hepatitis C Elimination Program and the CNHS in the HIV epidemic program. Dr. Mera is a board certified in infectious diseases by the American Board of Internal Medicines. Go ahead, Dr. Mera.
Thank you, Brian. Don't worry, I have a dog too, so I feel your pain. Okay, good morning, everyone. And once again, I want to thank the organizers for inviting me to present the Hep C Elimination Program. And I just want to mention that on Wednesday, Ms. Essex and I will be covering hepatitis C treatment, evaluation and treatment, more oriented for your, clinical program. This is more for individuals who are wanting to go a little bit beyond the treatment of an individual patient and look at the possibility of eliminating hepatitis C in your area. So the way I've made my outline is, first is going to give you some information. Why do we need a hepatitis C elimination program? And second is basic concepts of hepatitis C elimination. Let's say you decide to do it. How can you do it, or what do you need? Tease out the concept of macro versus micro elimination. Then I'll give you our experience in the Cherokee Nation with the program. And finally, how can you contribute to elimination of hepatitis C in your community? Okay, in this slide, on the left-hand side, there are some basic statistics obtained from the CDC website on what's going on with hepatitis C in our country, in the United States. So right now, as of 2016, which is a little bit 5 years old, but I think the estimates are reasonable, probably a little bit higher now. There are 2.4 million individuals estimated living with hepatitis C. There's over 3,000 cases of reported acute hepatitis C every year, but when you jump to the graph on the right, you can see that there's a discrepancy between the reported and the estimated. So we know that for every case of reported hepatitis C, there's at least 17 cases that have not been reported. Then we know that, when I started working on hepatitis C in 10 years ago, it was more of a baby boomer problem. And now, unfortunately, due to the opioid epidemic in our country, younger individuals than baby boomers are having the burden of the acute cases, and also the chronic cases are evenly distributed. And then the other problem we have is there are some populations that are disproportionately affected by hepatitis C, specifically American Indians, Alaska Natives, the people that we serve, have higher rates, but then other ethnic groups like Hispanic and other, not ethnic, but other special groups like people who inject drugs or people with HIV have a higher prevalence of hepatitis C. And there's a lot of challenges that are listed there that I will cover in my talk. I don't want to spend more time going through each bullet, but you have them there to look at for your reference. So American Indians and Alaska Natives are disproportionately affected by hepatitis C. On the left, you can see a map of the United States looking at American Indian and Alaska Native population as a percentage of county population. And although we've had a census in 2020, the data that I have available is the one from the 2010 census. So the darker the green color, the higher the American Indian, Alaska Native population in those areas. And you can see that the majority of the Native American populations is in the states of California and Oklahoma. They have the highest rates of AIAN population. And this represents the 573 federally recognized tribes and about 5.2 Native Americans in the United States overall. So when you look at all the benchmarks for hepatitis C, unfortunately, Native Americans have the highest cases of acute infection, the highest mortality rates, and the highest rates of liver cancer due to hepatitis C. So they're disproportionately affected compared to other racial groups or ethnic groups. Then when we look at a map of the hepatitis C elimination programs in the United States, which are depicted in the yellow color, we can see that first, it's not a national it's not a national program. These are micro elimination programs that cover sometimes states, sometimes cities. And in the case of Oklahoma, it's basically our Cherokee Nation, a tribal program. And most of the states with the highest prevalence, which is Oklahoma, prevalence of Native Americans or rates of Native American population, let me word it correctly, which is California and Oklahoma, for the most part, they don't have elimination programs. And the Southwest is pretty free of HCV elimination programs, which is very concerning. And I think hopefully this will change in the future. We've been doing a lot of work with Brian and the Portland group to try to motivate Hep C elimination programs in the future. So I have my hopes that this will be changing. So basic concepts of Hep C elimination. So I just wanted, this is of historical value, but traditionally the terminology was a little bit different. So eradication of an infectious disease or a disease for that matter, any disease for that matter, was defined as the absence of new infections globally. And the only example I can give you is smallpox. That's the only infectious disease that has been eradicated from the world. Then elimination was also the absence of new infections regionally. And the best examples could be polio. There are areas of the world in which there's no polio, but there are still some hot spots, and polio cannot be eradicated yet, but it has been eliminated from many regions. And then control is when you cannot eliminate or eradicate a disease, but you bring it down to such a low level that it becomes it stops being a public health burden. And this is where our definition jumps in today. Today, the WHO and the United States National Academy of Sciences defines hepatitis C elimination as eliminating hepatitis C as a public health problem, which was the old definition for control. I just want to clarify that, because if you're a good medical historian, you'll say, well, this is not the definition that I see in different books. Now, once you decide that you want to eliminate an infectious disease, there are criteria of feasibility for elimination. And as you can see, hepatitis C will meet those criteria. The first one is that the infection cannot have a non-human reservoir or cannot multiply in the environment. And hepatitis C only replicates the virus in humans. Then you have to have simple and accurate diagnostic tools, and we do. And then you have to have practical interventions to interrupt transmission. And we have syringe service programs, medication-assisted programs, treatment as prevention. So we have those tools. And finally, it has to be curable in most cases. And we have curative treatment for hepatitis C, which is remarkable because it's one of the few, if not only, chronic infectious diseases that we can cure. And for that matter, any chronic disease that we can cure. I wish we had the same treatments for diabetes. Give a patient a pill for 12 weeks and their diabetes is gone. But we don't have that yet. Now, when you embark in a hepatitis C elimination project, you need to understand that there's two major target populations. One are the chronically infected individuals. They're not transmitting the disease to anyone, but they will be suffering the burden of the disease. And you want to prevent these individuals from developing cirrhosis or dying of hepatitis C related problems. So when if you want to target that to meet one of the definitions of elimination, you will target the older individuals, the birth cohort, or anyone who's at least has had 20 years of infection of hepatitis C or multiple liver comorbidities. And I added this bullet here because we are seeing people that are 35 years old and have cirrhosis. So they're born after 1965, but they've been infected at very young ages, or they have multiple comorbidities. They are drinking alcohol excessively, or they have hepatitis B or HIV, and that makes the acceleration to cirrhosis much faster. Then, if you want to really prevent transmission, you have to target the young population who is for most the one that are still injecting drugs, and they are the ones that are transmitting the infection. And you need to focus also on places where you can find these individuals to offer them and get them into treatment. And usually is focusing on syringe service programs or medication assisted treatment programs, or in the correctional system, which you will get your bang for your buck and trying to find these people and offering them treatment. And also not a big component of the pandemic, which is also like COVID, a pandemic, it's worldwide. Addressing sexual transmission in men who have sex with men also needs to be done because there is outbreaks of hepatitis C in this population. So when you're looking, every time you start a program, you want to define your goals, your objectives or targets. Objectives and targets could be synonym, and then your strategy. And in the United States, we have the National Viral Hepatitis Action Plan that has updated their goals and objectives, the National Academy of Sciences, and we also are influenced by the World Health Organization because we are part of the World Health Organization. And they all have, I would say, very similar goals and objectives. So the main goals are to reduce the acute cases or the incidence of hepatitis C, and to reduce or decrease mortality from hepatitis C. Now I'm not going to go through each bullet or line, but you can see that usually it's 80 to 90% reduction of acute cases by 2030 and about 65% reduction in mortality by 2030. Okay, so what is the difference? You'll hear the word micro-elimination a lot. So what's the difference between macro and micro-elimination? So macro-elimination is when an elimination project is launched at a national level. It covers the whole population. So let's say in the United States, we decided to do this. The government decided to do this. It would be the government who's deciding to do this, and they would be the main stakeholder. Everybody in the US who has hepatitis C would be eligible for the program. We would have widespread resources available to screen, engage patients in care. Treatment should be readily available, and harm reduction interventions also. And the information used to design the program usually comes from mathematical modeling or population-based information. And examples of macro-elimination programs are, for example, the country of Georgia, Iceland, Australia, and there are several other countries that have started robust HCV elimination programs. Unfortunately, in the United States, although we have a lot of plans and a lot of guidance, we don't have a macro-elimination project because of the things that we don't have that I just mentioned. So micro-elimination is when a project for elimination, it's launched at a local level. It covers not the whole population, but a specific population. You have many stakeholders in which the government could be one of those stakeholders, or a government agency, let me put it that way, but not necessarily. And you have other non-governmental stakeholders in place. Your resources are limited, so you need to focus your strategy on screening your target population, engaging your target population in care, and applying all the rest of the interventions that you need to eliminate the disease in that population. Interventions also are driven by local data and the resources that you have. And examples of that are the Veteran Administration's health system has an elimination program. There are several states. I put Washington State here as an example, but there are other states that have embarked on this. And then there are tribal communities, the Lummi tribe in Washington State, Cherokee Nation, and there are other tribes that are looking into starting hepatitis C elimination program soon. Now, to have a micro elimination program, it might sound easier, like you're off the hook on many things, but really you're not. I mean, you still have to have a very organized and robust program, and you need a plan in place on how are you going to tailor your resources and services to overcome the barriers that you have right now, that you can't eliminate hepatitis C with what you're already doing. And you have to have a very defined population of interest within your scope. And you have to have a time frame. It's not like I'm starting Hep C elimination and, you know, whenever it happens, it happens. No, you have to have some objectives that include time. You have to have achievable annual targets. You need to have multi-stakeholder process in place. And you need to not only have progress and outcomes monitored, but you need to report them publicly. So there is a responsibility and accountability for having a microelimination program. On the right, I just made a list of examples of populations that you can target. So let's say you're a tribe, you can decide, okay, I'm going to target every tribal citizen, or I can target any tribal citizen who accesses the health system. Or I can say, I'm only going to target the hemodialysis units in our tribal area, or only the HIV, Hep C co-infected individuals, and so on and so forth. So you have to define the target population. And one advice I have, it's make sure that you think you can achieve those goals and be successful, because that will increase the occurrence of other microelimination programs in your area, especially if you have some degree of success. So let me tell you a little bit in depth about the Cherokee Nation experience with Hep C elimination. I'll try to tell you kind of the story and what really helped us and how, what we need to do to actually achieve elimination. So I know that most of the audience knows where we are, but in case someone doesn't, Cherokee Nation is a sovereign tribal nation located in northeastern Oklahoma, and we serve about 130,000 Native Americans that live in the trust land and surroundings. In the map on the right, the little red crosses are outlying tribal health centers from the Cherokee Nation. And then we have one hospital in Tahlequah, Oklahoma, which is the capital of the Cherokee Nation of Oklahoma. So in December of 2011, I was hired to be the infectious disease specialist for Cherokee Nation. And when I was hired, one of the things they made, that they thought it was very important is for me to tackle the hepatitis C problem. And when I started in 2012, I found that we already had a list of 263 HCV RNA positive individuals that were on a waiting list to be treated. And working with the local epidemiologist and looking at the number of people that had been screened until that date, that were about 4,000 individuals, they estimated that our seroprevalence was about 6%, between 5.8 or 6.1, depending on the age group. And that they estimated that based on that seroprevalence, that we probably had about 1,800 current infections. So that kind of got me a little bit worried, because I was worried that I had 260 people to treat. And now I'm getting the information that maybe we actually have 1,800 that we don't know about, but that are living, in our population. So the first question that came to mind is, how do I expand screening and how to expand clinical capacity? Screening to detect those undetected, and then clinical capacity to treat them all. And so the first things that we did back in 2013, for screening, we changed our policy and we adopted the CDC baby boomer screening policy that was published in 2012. And we also implemented an electronic healthcare reminder to remind providers that they need to screen patients for hepatitis C. And regarding clinic expansion, I got in contact with the people from University of New Mexico, Dr. Carla Thornton, Dr. Aurora, and Paula Deming. They're all in this photograph. And they introduced me to Project ECHO, which is a way that you could train clinicians in treating different diseases, including hepatitis C. And that was a way to expand clinical capacity. So, let me show you some of the results of those interventions. The first one was, I'm going to show you here, is what did the electronic healthcare reminders did. So basically, an EHR health reminder just tells you if a patient is a candidate for hepatitis C treatment. I'm sorry, for hepatitis C testing, based on criteria that you put in the electronic healthcare reminder. So in this graph, the blue columns are a period July 12 through June of 13, in which we don't have any reminders in place. And these are the 8 outlying clinics and the hospital. And what we're measuring here is what percentage of patients who met screening criteria, which at that time was basically baby boomers and people at high risk for hepatitis C, were actually screened. And you can see that the percentage of screening was below 15 or 10% for most of the clinics. When we introduced the reminder, it went up to about 30 to 40%, depending on the clinic. But we thought that that was great. It had improved, but not as much as we thought. And we quickly figured out that we were asking the wrong person to do the screening. We were asking the provider. And then someone said, oh, the nurses are much better and, following algorithms and structure. And when we trained the nurses to look at the electronic healthcare reminder, we went up to 60, 70% of screening in each clinic. So that was a really interesting finding that we still do today. Then on the graph on the left, the top line, the solid line with the dotted line, shows the baby boomer screening, and you can see how it increased from October of 2012 through July of 15, and that was basically due to the electronic health reminder and education to our providers. We did a lot of workshop with our providers. But then on the bottom, the interesting thing is that the younger population, also the screening increased. And I think this was just due, because that wasn't in the reminder. The reminder would say screen baby boomers and people at risk, but I think there was more awareness of that hepatitis C was an issue and that more people were at risk. And then on the graph on the right is basically the columns are number of patients treated each month. And you can see here in July 2014, we started our ECHO program. And you can, but also have to admit, we also had DAAs that year, direct antiviral agents. But you can see how the treatment of patients increased dramatically after ECHO and the availability of medications. So we're finishing 2015 and we're very excited and happy. And then we do our Cascade of Care. And okay, it did improve from before, which only had 20 patients treated, but still screening was a problem. Of the 1,800 expected individuals that were positive, we can only detected about 388. But the interesting thing is when they were engaged in care, the majority, more than 70%, started treatment. So we were doing okay on the clinical side, not great, but okay. But we're doing very poor on the screening side. And you will say, well, why? Because I'm telling you that 70% of the patients who come to those clinics get screened. But what we really found out is that when they come to the primary care, they get screened. If a patient comes in and goes to the pharmacy only or physical therapy only, they won't get screened. And they were counted as part of our denominator. That's why these percentages are so low. So in 2015, that's when we decided, okay, we got enough problems with hepatitis C, probably as many others, but we actually know we're quantifying the problem. So let's do something about it. And we started designing an HCV elimination program. Now, we didn't know the concept of microelimination back then. We learned that concept, came published later after we started, but I'm applying that concept to what our thoughts were, which were very similar. So what population were we going to target? And we decided to target every Native American that came to our health system. Who are going to be our stakeholders? And I'll show you that on our next slide. What will be our goals, objective, and strategies? And I'll depict that in the next few slides. And basically, you're going through all the definitions or components of a microelimination program that I showed you on the slides before, but now I'm applying it to the questions on my program. And that's what you should do if you want to start a program. Start asking those questions and filling in the blanks. So what we did, we started, we had our stakeholders, which were the CDC, the University of Oklahoma, the University of New Mexico, the Oklahoma State Health Department, Cardia, and also the Gilead Foundation. We provided us with money to start our program. The money could not be used to buy medication, so we had to do a different thing to how we were going to get antivirals. but the money did help us to, coordinate our program and jumpstart it. And the goal was to eliminate hepatitis C from individuals who access the Cherokee Nation health services. Remember that the WHO, National Academy of Sciences, and National Hepatitis C Action Plan did not give their goals when we started. They came later, a year later. So we had to design our own program objectives and goals. And they're depicted here. And the objectives, we thought that 85% was a reasonable, achievable number, and that's why we chose those numbers. So it was to screen 85% of those who access the Cherokee Nation health system who met criteria, to evaluate 85% of those with current infection, initiate HCV treatment in 85% of those who were evaluated, and document cure in 85%. Those were our program objectives. So what were our strategies? So remember, goals is what you want to do. Objectives or targets are how are you going to measure what you're going to do? And then strategies is how are you going to do it? And our strategies were implement universal screening, which now it's a recommendation from CDC and the task force, and AASLD. But back then it was just a advice we got from CDC that probably this was a good idea to do, but we actually were the first ones to start doing it in our system. Expand screening sites beyond primary care. Let's do it in urgent care. Let's do it in hospitalized individuals, women's clinic, etc. Let's do it in the jail if we can, homeless shelters. Let's do it in community events. Expand screening take screening to the people. Don't expect all the people to come to your primary care office to get screened. And then we used some new screening modalities, which included point of care rapid test. That we did this basically in the dental clinics, and something called Reflex laboratory trigger screening, which I'll explain in the next slide. And regarding treatment, we expanded Project Echo. We had, I showed you, and from 2012 to 15, we had 7 providers, and then we expanded the number of providers, and we focused on pharmacists because they were more willing to do it than most of our providers. And we tried to incorporate everything the patient needed on one visit. It's a one-stop shop model, and I'll show you a little bit about that later. And we also incorporated community health workers. So Reflex lab trigger screening. Why am I spending one slide for this? Because I think it's probably the best bang for your buck if you can implement it, which is not always easy. So basically the concept is that a patient presents to lab for routine labs or other phlebotomy. Example is they come to the emergency room and for a pneumonia, and the provider orders a CBC, a CMP. An extra tube is drawn by the phlebotomist. That extra tube is put, the way we do it, we collect those tubes, and one of our nurses, one of our employees from our department picks those tubes up every day from the lab. Then we look at the computer if these patients have been screened for hepatitis C. And then if they have not, we look if they have an informed consent sign that allows us to do the tests that we think are important for the patient. And if they do, then we drop a hepatitis C test. Now this process is completed by hand. It's not an automated process. It requires staff, but it could be done automatically. I haven't been able to do that in our system yet, but I know that there are some ERs in the United States that have this automated, and that would be the ideal solution to increase your screening. So I'll show you now what impact this had in our system. So this is August of 2015. These are the number of patients screened per month. And we started our elimination program in October or November of 2015. So in August, we were screening about 500 people per month. When we implemented universal screening, it automatically went double, triple, almost between 2.5 to 3 times as much screening per month. And when we implemented RLTS, or Reflex Lab Trigger Screening, it went up to almost 3,000 patients screened per month. And these are all patients that meet criteria for screening by universal screening criteria. And then we had to stop RLTS because there was some debate that this is really not opt-out, and there was some discussion, and the importance is see how it drops immediately. We stop doing it, and the screening drops dramatically. I mean, we don't have a control group here, but this is as good as they can get of showing an intervention, and when you take it away, how the things just drop down. And we continue. We added other things like dental screening implemented. We had lost our electronic health care reminder because we switched EHRs in 2015, but then we recuperated here, and that's why you see this here. Now we have, we started about a year ago doing lab trigger screening, and our numbers have gone up again because it was decided that that was the right thing to do, and that people were actually signing out general informed consent, and that should be enough, considering that we have a problem with hepatitis C in our community. So the other thing that we found is that more than 60% of the seropositive individuals were younger than baby boomers, which supported our universal screening policy. And we took a deeper dive and said, okay, during those 3 months in which we did lab trigger screening, where were we finding these patients? And lo and behold, not surprisingly, 67% of these patients were in the emergency room and the urgent care department, the ones that we were testing. And we found 97, in that 3 months period, 97 unique, newly diagnosed seropositive individuals for hepatitis C. So this is why I say, if you could implement this, this will get you a lot of new individuals identified that you can treat. So the lessons learned during these years on the screening part was that universal screening had the greatest impact on screening and expansion, along with lab trigger screening. That we found a hotspot, which is our urgent care and ED, and we are always trying to improve in that area. But that HCV screening is not embraced beyond primary care in general. We had a hard time convincing other units like ortho or physical therapy to implement Hep C screening in their unit. But you may be more successful. Reflex antibody to RNA also increased our RNA testing from 65 to 85%. We're doing it in the hospital. It does not always happen in the outlying clinics. And point of care testing may be useful in some areas. It was extremely useful in our dental department, which we still screen for hepatitis C. But in other areas, it complicated the workflow. So you have to, kind of gauge what you can do or not do, but it's something to have in mind. So in this slide here, I just want to show you the impact of the different screening modalities in different time periods. So 2006 to 2012, only high-risk patients were being screened at the discretion of the provider, meaning maybe someone who had cirrhosis would get a Hep C test done or had elevated LFTs. And the number of unique patients screened per month was 57. When we implemented the baby boomer screening and the EHR reminders and provider education, we jumped to 357 patients screened per month. And when we started our elimination program, in which we included universal screening, all the strategies I mentioned above, we tripled that number of screening per patients to an average of, this is average, of 900 patients per month. So I think this is a good example of the utility of all these programs. And here you have the percentage of population screened during those periods. Like the first period, only less than 7% of the population had been screened for Hep C, the population that should be screened. And in 2018, we're up to 54%. I'm not going to spend much time on this slide because I've showed it to you in the previous period, but ECHO was great to increase providers. One thing I want to mention is that once, I don't think we actually need 24 providers treating Hep C in our system. I'm happy they know how to do it because, providers come and go, and sometimes people that know how to treat something leave. But once you hit a certain threshold, you don't increase number of treatments per month. And that's because the bottleneck, it's not the capacity to treat, but the capacity to engage patients in care, which is a different problem. So here, this is kind of our model. We do universal screening. We have a patient navigator trying to call the positive patients to the clinic. We evaluate them in the clinic, and we have a comprehensive multidisciplinary team. We have our nurse, our behavioral health counselor on site, very similar to what I copied this from Dr. Brown's hospital in Eastern Bend. When I went to visit them, they had all that in a pod. They had everybody said, we're going to do this. And sorry for copying Harry, but we did it. And we have an MAT provider there, and a Hep C provider is the same person. A case manager to procure DAAs, our pharmacist is there, and a community health worker is there, and then takes off to their homes when that needs to be done. So we found that Project ECHO was key in training primary care providers, but once you reach a certain threshold, you can increase the number of FC providers, you don't increase the number of patients being treated, because then the rate limiting factor depends on difficult to reach patients, that's how we call them, and the patients call us difficult to reach doctors. They can't find us. So you need to look at both angles. Patients have other priorities, or they're incarcerated, or you have delays in acquiring their medications, and that all puts a strain on, and that's the areas that we really need to work hard to improve our cascade of care. So I'm not going to spend a lot of time here, but this is our cascade of care in 2019. We are updating the one now. I don't have the latest, but you can see that we're doing better, but we're not there yet. There's about a 20% drop in each part of the cascade. The first one, why haven't we screened everybody? Because not everybody accesses our screening services. So we need to think on how can we access those people in a different way. And then people fall out through the gaps, and there's many reasons. The main reason I think today is not having medication on the shelf, because there's a lot of people, like these 75% that are linked to care. Linked to care here means they were seen by a Hep C provider, someone who could prescribe the medication. And only 55% started treatment. They should have started that day. It's because we don't have the medications on site, and very few people, maybe the VA is the only one who does that, or some other sites. But that's a critical step that needs to be fixed. Anyway, the cascade is very useful because, as you can see here and review later, there are many reasons why there are these gaps, and you need to attack those gaps to improve your cascade of care. So when we looked at our goals, so HCV screening, it's interesting. If you look at screening overall, we were only at 51%. But when we looked at a screening where a site where HCV screening was actually done, like the urgent care or the primary care, it was 66% screening rates. But when we looked at the primary care, it's 87%. That just tells you that you need to be flexible and have screening of Hep C everywhere you can. Linkage to care was 75%, treatment initiation 74%, and cure rate was 77% on intention to treat, but 96% on those who had an SVR12 available. And that's very similar to other real-world sites. Okay, so we had a group called the Polaris Institute analyze our data and do some mathematical modeling and tell us. The question was, are we going to reach the 2030 goals, the WHO, the National Viral Hepatitis Action Plan? And when they looked at liver-related, hepatitis C liver-related deaths, it says, yes, you are. You're going to be below 65% at 2030 the way you're doing it. When they looked at incidence of liver cancer, they said, yes, you're going to meet the goals. You're going to be less than one cancer per year when you get to 2030. And decompensated cirrhosis, the same thing. So all the morbidity and mortality goals, we were going to meet based on their mathematical model. The one that we were not going to meet is incidence. Here is this black line reflects incidence of acute hepatitis C in the Cherokee Nation. So 2015, they estimated that we had about 120, give or take, new cases per year. The way we're working, by 2030, we're still going to have 60. We're going to be improved, but not meet the 85% goal of reduction. So they modeled and said, if you increase your treatment by almost 400 patients per year, and we're doing 160 right now, by 2030, you would meet the goal, maybe. But the only way to actually meet the goal is to start syringe service programs. So this is the green dotted line, is if we start syringe service programs, not only can we meet HCV elimination goals by 2030, we could meet them by 2025. So that's good news, is that Cherokee Nation is working very hard on legalizing syringe service programs. And I think that the process, I hope, is going to turn out well. So if everything turns out well and we incorporate these strategies, we will be able to eliminate hepatitis C definitely by 2030, but maybe earlier. So summary of successes, universal screening definitely is something that now it's recommended, so you won't have a hard time implementing it. When we did it, it was a lot of discussions because it wasn't recommended at that time. Reflex lab trigger screening, it has its ups and downs, but it's overall successful. And you could choose the right site to do it and try to automate it. Project Echo, foster direct connections with other providers, enable 24 HCV treaters in our system. And I cannot say, more good things about Project Echo because I just ran out of the vocabulary, but it's been great for us. One-stop shop, it's a holistic patient evaluation. So, the other day I was in the clinic and I had a patient who was hepatitis C positive, RNA detected, HIV positive, newly diagnosed, and he was using heroin. So on that same visit, we got the patient started on, we couldn't do the Suboxone induction that day because he had injected heroin that morning, but he got scheduled for Suboxone induction on the next day. We started him on we procured his hepatitis C medications, and we started him that day on HIV medications. So that was a holistic approach to treating that individual. And of course, we got behavioral health on board because the patient had depression, et cetera. That's what you need to shoot for. It's not easy to get there, but you can get there with being organized and with some resources and a lot of work. And medication-assisted treatment is also important to implement in your clinics. So how can HCV elimination be achieved in the Cherokee Nation? So here are the things that we have and can expand. So we don't have the SSPs yet, but I'm confident that we'll have them very soon. Expand one-stop shop to all our clinics. We're doing it at Tahlequah, but this is not happening in every clinic. It's happening in some of them. Incentivize screening and treatment. The VA has done a good job at that, and you have to incentivize everybody, the whole team, not only the provider, the nurses, the pharmacists, the medical assistants, because we all work as a team. And test and treat approach, point of care testing, Reflex RNA, and community outreach with telemedicine and mobile units would be ideal to have this started. And what do we really need? We need a stigma-free environment. Unfortunately, hepatitis C still has a lot of stigma attached to it. That prevents successful treatment of many patients. We need to decriminalize injection drug use. Not only have syringe service programs, but which is not the same as decriminalizing injection drug use. And we need to test and treat. Like I said here, point of care testing, point of care RNA, we don't have it yet in the US, but we should. I think the COVID pandemic has taught us many lessons that suddenly through EUA, we have all these treatments and diagnostic tools that we need. And we could have an EUA for RNA testing point of care. I mean, there are machines that do it, but it's not FDA approved yet, but we should get that. And direct antiviral agents on the shelf, it's something that we need if we want to really achieve elimination. This is like having a patient with hypertension and telling them that it'll take you a month to get his lisinopril. 50% chances he won't come back. So as a primary care provider, how can you contribute to elimination? Well, you could be the champion of your microelimination program. You can start, what we did 5 or 6 years ago. It takes time, effort, but it will be worth your time. Or if you feel that that is not possible, that it's not the right time for you to do it, or you don't have enough resources or support, you can always be a champion in your own workplace by promoting universal screening of your patients, be an advocate for MAT and SSP programs if you don't have them, treat all the patients you can with chronic infections, and treat people who inject drugs. And you in your small world, but very important world, will be able to achieve a very important task that if everybody does it, you would have a microelimination program in place without even planning for it. So elimination of Hep C is possible by the year 2030. Effective interventions are available. Micro-elimination programs are feasible and needed in the absence of macro-elimination programs, but it takes planning and commitment, and you need to prioritize your issues to meet the goals that you need to meet. And these are my acknowledgements, and I'll stop there and be happy to take any questions.
Awesome. If you have any questions, you can feel free to unmute yourself and ask your question. You can type it in the chat box, raise your hand, whichever you prefer.
So I just had a question. I think I missed, or I didn't completely understand. Could you go back to maybe the cure rate slide? It was quite a few slides back. And I guess I guess I'd ask you to re-explain it, or maybe explain it in, yeah, that one, the next.
Yeah, sure.
Next slide, past this one, Jorge. This slide, yeah.
Okay.
That last bar down there, what's the difference between the intention to treat and the protocol? Because
Sure.
I mean, 77 is a good, but 97 is way better.
Yeah, sorry, I went a little bit fast here. So intention to treat would be anybody that you started them on antiviral medication. That would be your denominator. And then numerator would be, let's say you started 100 people on HCV treatment, but you only have documented cure in 77 of them.
Okay.
And that's your intention to treat. But when you use as your denominator everybody who actually had a lab of cure done, then you're actually measuring how the DAA work, which it works, because the problem is, Harry, that many patients, and let me show you this here. Let me go to this slide. When you go from initiated treatment to cure, you see you have the 77%. So the drop is because they're either on treatment and you still can't measure if they were cured or not. But some of them may have finished treatment, but you need to wait 12 weeks until you finish treatment to determine if they're cured. But these are the minority. The majority are lost to follow. The patient completed treatment and they left and they never came back. Now, the chances are that they probably are cured because they completed their treatment, but you can't really document that. And that's why this is intention to treat, and this is per protocol treatment analysis, which includes you have to have an SVR12 lab drawn 12 weeks after you stop treatment.
Okay, yeah, that's much more clear now. Thank you.
No, you're welcome. And except unless you're so in clinical trials, you'll see this number, because clinical trials select patients that will probably be compliant and adherent. That's what. But when you go to real world studies, you'll find between the 70 and 80% of intention to treat cure rates.
Right. So my experience here at the Eastern Band of Cherokee is pretty anecdotal, because I'm mostly retired from clinical medicine now. What I do is I fill in on an intermittent basis on the inpatient service. I don't see outpatients anymore. And what I see in terms of our hepatitis C positive population, just anecdotally, it's more than 95% of them are IV drug users, either past or present. And because I'm seeing them in the hospital, I would say the vast majority of that group are present IV drug users. They're still at least intermittently using IV drugs. Maybe they're not every day, but they from time to time go back to their IV drug use. There seems to be in that population, we get them in the hospital for some reason. It's often an abscess, or sometimes it's liver involvement. But while they're in the hospital, they have great intentions of curing their hepatitis C. We talk to them about it. They get started on treatment. but there's a pretty high percentage who fail to complete treatment because they go back, they're discharged from the hospital, maybe they follow up a couple of times with outpatient, and then they go back to this unfortunate lifestyle of IV drug use in which they don't follow up with medical care or anything else. And so we see people who get a few weeks of treatment, but they don't complete it. So that's by way of comment, but I have a question about that. Are we actually possibly doing harm by partially treating people, or overall, is that a good thing to do, to partially treat people?
That's a great question. So what are the cons of someone doing suboptimal therapy? Not enough to cure them is that you may generate Hep C viral strains that become resistant to the antivirals that we're using. Now, so far, we haven't run into, at least in my experience, a big problem with that. Patients are responsive to 95%, the ones that you can measure cure respond to treatment. So the pro of doing that is that first, we see a lot of patients that 4 weeks of treatment cuts it and they're cured, that they don't really need the till 8 weeks. And we've seen more than a handful of those. And so you may be curing a lot. At least during the weeks that they're taking the medication, they probably are not infectious and they're not transmitting the infection. So that also has a unmeasurable health impact, or not easy to measure public health impact in your community. So you will have a group of those patients. I think it's still worth to try to treat them, and also to try to give them all the resources for them to be successful in the treatment. The problem that we have is that they don't show up to the clinic. They leave the hospital and we don't see them again. And we can't start treatment in the hospital. But I'm pretty sure that if we could have given them the 8 weeks of treatment, the 2 big bottles of pills, and tell them, look, if you don't even want to come back, it's fine. I mean, we wish to see you, but take your pills every day for 8 weeks and you're going to be cured. And also, be engaged with your syringe service program so you don't get reinfected. I think that at the end of the day, the good is going to be more than the possibility of having a resistant virus. But I could be wrong, and time will tell. But that's what I would try to do. My major issues are I don't have medication to give them in the hospital, because by the time I get it, the patients are gone. And that's something that we need to try to solve as a community. We've been too tolerant to that for a long time. And the other one is, we are still lacking. We have a pretty robust behavioral health service, but I think the demand is too high, and not everybody can be seen quickly. And you can't have someone injecting drugs and waiting 2, 3, or 4 weeks for their appointment. They need to be like there today. And of course, some will fall out and some will not come back. But I think you're still going to capture a lot that you can help them change their lives.
Yeah, it's, by the way, this was an absolutely excellent presentation. I've heard a version of this talk before, some time back, but I learned a lot from this talk. So one of the things that I learned is that the issues seem to be fairly universal. The issues that you have out in Oklahoma are exactly the same issues that we have here in North Carolina. We have the same challenges. And I guess the one advantage we have here that you don't have in Oklahoma is we have a needle exchange program.
Yes.
However, and again, this is all anecdotal. I don't know what the numbers are, which is shameful to say for somebody who has the title of medical epidemiologist, but despite our needle and syringe exchange program, I think the problem is many of these people were infected before we had that needle exchange program. So we have a fairly large group of IV drug using people here, and a very high percentage, close to 100%, are hepatitis C antibody positive. And it's amazing and disheartening at the same time to see how many people, how easily it seems that this virus is transmitted among that population. And so our needle exchange program may be making an inroad, but I have not seen a huge impact from it yet in terms of lowering, probably because most people were already infected when we started it. But I think maybe going forward, we may cut down on transmission, and that will be to the good.
No, definitely. And don't worry, because these are numbers hard to get. I mean, this information, it's not easy to obtain. You have to have very thorough, detailed studies, and even then, nothing's perfect. But you look, like you don't have the numbers, but I'm sure that, and you're right, you know, most people get infected within the first 3 years of injection drug use through Hep C. So you have people who've been injecting for 5 or 6 years. If they're going to be infected, they're probably infected already. But your program, the needle and syringe, will prevent them from infecting other people. So maybe you won't find an initial decrease, but you won't find the increase either of, you know, more and more people getting infected. So, I mean, there's a lot of evidence that these programs are good. Now, you need to give enough syringes and needles, and I believe you guys are doing it because I've heard your program director once give a talk, and I was very impressed by it. But you need to give like 300 needle and syringes per user per year to make sure that you saturate the environment with clean needles and syringes, or else it doesn't have the impact of Hep C or HIV reduction. And yeah, you know, we may be starting our program. We're actually using your program as our standard. So I guess that the people that are going to be working in our program will be in very close communication with the programs that you guys have, which is marvelous. And you have everything ideal to eliminate Hep C, everything. You know, I know how your clinics work. I know you have the syringe program, you have MAT. I think you just need a little bit of coordination of everybody working together with a program with defined goals and objectives that everybody embraces, and you should be able to eliminate Hep C like real quickly if you do that. It's just you're just one step away from being able to do it. You have all the tools.
Right. Well,
Anyway,
thanks again
thank you
for
very
being
much.
here.
Thank you very much for the invitation. And are there any other questions?